Welcome to Myopia, Theories of Development and Progression. As we've discussed before, myopia prevalence in the United States can be, depending on the study you look at, between 25 and 60%. More modern figures push it closer to that 60%. And it can be up to 80% in some Asian countries. This means that there's estimated to be up to 2.5 billion myopes by the year 2020. And this represents a significant risk factor for retinal detachment, chorioretinal abnormalities, as well as other diseases, due to the axial elongation and the stretching of the retina. For the remainder of this talk, we are largely talking about juvenile myopia, or myopia between the ages of about 7 and 13. And this is largely due to changes in axial length, whereas the anterior optics of the cornea and the lens remain relatively stable during this type of myopia development. We've known for a long time that abnormal axial length can lead to a wide range of diseases, including retinal detachment, possibly glaucoma, cataracts, as well as maculopathies. Here's an example of somebody with a high level of myopia that did develop a retinal detachment, Teddy Roosevelt. We know from emmetropization experiments that the retina responds to defocus and specifically the sign of defocus. If we place the image in front of the retina, the eye will either grow or stop growing to compensate for this, thereby optimizing vision. Conversely, if we have a hyperopic defocus or an image behind the retina, the eye will grow in length to meet that focal position and maximize vision. We know this is true in a wide variety of animals, including chickens, primates, fish, as well as dogs, and this represents the fact that this is very well preserved regardless of whether you're prey or predator. You need to optimize your vision to have the best chance of surviving and progressing. There are a number of theories of myopia development and progression that generally go into these four types of categories: peripheral refractive error, accommodation and accommodative lag, retinal luminance, and environmental versions. Let's first start with peripheral refractive error. We've known from previous experiments and previous talks that altering the peripheral retina with lenses or with occluders will result in the appropriate growth of the eye into the direction of the defocus. So this means that localized retina is responsible for the determination of growth. We also know that the fovea itself, if we destroy the fovea, it has no effect on emmetropization and normal refractive development. So the peripheral retina is a critical component to normal emmetropization. We've also known for a long time that the refractive error across the eye is not constant. Up until this point, we've only been talking really about central refraction at the fovea. But refractive error can vary across the whole eye. The periphery could be relatively hyperopic or myopic compared to the fovea. Also, astigmatism increases as we move away from the fovea. Here's two examples. Well, the one in red is a hyperopic periphery. So this might have a signal that you might want to grow back in the periphery. Conversely, the lower one is a myopic periphery where the image is in front of the retina relative to the fovea. And this would suggest stopping or slowing growth. We've known for a long time that in humans, especially starting with research by Hoogerheide, that the peripheral refractive error was important to the development of myopia. Patients that exhibited relatively hyperopic peripheries were more likely to develop myopia. Since then, there have been multiple reports have shown a tendency towards relative hyperopia in the periphery of myopes. Why does this matter? Well, in an emmetrope or somebody who has the same refractive error across the whole eye, when we focus the fovea, all locations across that retina are equally focused, and so there's no signal for growth or slowing growth in either direction. However, if the eye is relatively prolate due to myopia, the periphery shows relative hyperopia, and this hyperopic defocus could be a signal to keep on progressing. And so if you correct the person's fovea, now all we're left in the periphery with is hyperopic defocus that keeps on signaling growth throughout the person's developmental period until they stop growing at the age of 16, 17, 18, 19. And we can see this in OCT images as well. The bottom image is actually a 3.5 diopter myope, and the top image is an emmetrope. What we see in these two images is that the myope's retina is relatively more curved. That means it's more prolate. And we can see that that actually will correlate to actually a hyperopic periphery. And so this patient at the bottom has a higher possibility of progressing compared to the lower image. And this change in this shape actually increases with refractive error. This is one patient measured at 25 millimeters in 2012, and at 2015, they're measured at 25.5 millimeters. And there's been a corresponding about diopter change in their myopia. What we see, though, is that the retina becomes more curved or more prolate. And that suggests this person has hyperopia in the periphery relative to its central refraction. There's other theories of myopia development and progression. Accommodation and accommodative lag have been strongly indicated at times throughout history with myopia development. We have a number of theories. When we know from experience and from studies, the rate of progression by time varies. So people progress more during school times and less during the summer times when they're not studying. We also know that occupations tend to have higher levels of myopia depending upon how much near work they do. University students, as an example, have high levels of myopia, whereas laborers and craftsmen tend to have lower levels of myopia. We've also known that when you introduce school and education into a system, you see a shift from more hyperopia to more myopia as you introduce education into school systems and to different populations. There's been plenty of evidence that shows that near work maybe play a critical role during myopia development. Now, how might that happen, though? We discussed from emmetropization models, we need a signal for the eye to grow longer. And that signal needs to be hyperopic or relatively behind the retina. Well, we do know that we think that myopes might have exhibited at one point something called higher levels of accommodative lag. It turns out that whenever we look at something up close, our sphere power does not perfectly correlate to the accommodative demand. So if we have a target at 40 centimeters, most patients don't exactly accommodate to 2.5 diopters. When a patient looks at near, they tend then to under-accommodate, and this is called accommodative lag. It was initially proposed that myopes tended to have a greater accommodative lag, which you can see here on the right. Emmetropes are the squares, myopes are in the triangles. On average, the myopes have a higher level of accommodative lag as they look at near targets. Now, what happens if they under-accommodate? That would leave the image hyperopically defocused or behind the retina. And so this might be a potential signal for axial elongation. However, looking at meta-analysis of accommodative lag and refractive error, on average, there's probably not much difference between myopes and hyperopes as far as their accommodative lag, with most groups on average under-accommodating about a half diopter. Now, this ultimately is possibly due to spherical aberration compensating for the difference, so the people are actually fairly well in focus. But more research is needed on this topic. Other theories of myopia development and progression include retinal luminance. So as we've discussed before, the more time we spend indoors, we have lower light levels. Lower light levels might be a signal to contribute to growth. High light levels might actually signal stop. So both for accommodation and for light levels, which you'll find throughout the research, it's hard to differentiate between accommodative models and indoor light level models because we tend to read inside, we tend to not read outside. But similar things we've discussed before, like summer rates of progression, tend to be lower than winter rates of progression for myopia. And this has been done in a number of studies across the globe. And there's been some intervention studies where spending more time outdoors seems to slow myopia progression compared to spending all day long indoors. We're not entirely certain the daylight mechanism. It might be distance viewing. It might be reduced image blur. It might be dopamine levels increasing in daylight, which slows growth. There's also a theory involved in environmental vergence, which has some correlations with retinal luminance and accommodative lag. If we look at our targets for urban versus outdoor environments tend to have a very uniform environment, and they have a relatively low level of working distance difference between the two of them. Remember, working distance is a negative power, so the closer something becomes, the more negative it becomes. Also, though, when we look across the visual field, things at distance, say an outdoor scene, or when we're outside looking at buildings, have all relatively low amounts of vergence. And that's because they're almost 20 feet away or longer. However, in indoor environments, things like computers and the wall across the room have varying levels of vergence. And that means some targets are inducing a high level of negative power, and some targets are inducing no negative power or negative vergence. And this means that depending on what we're looking at, we're receiving defocus signals at differential rates depending on what we're looking at and what we're in as far as the targets in the room we're in. Let's look at that a little closer. There are some alternative theories of myopia development, including diet and IOP, but they are largely discredited at this point in time. So what is the right theory? And the short answer is we don't know at this time. And it's ultimately probably a combination of some or all of these theories. If you have a negative vergence from the environment, you have a low light levels, and you have peripheral hyperopia, you might put yourself at a high risk of progressing. And so all these theories may be working together to create a high risk for myopia progression compared to other situations. Thank you.